Discussing new advances in pharmacotherapy for heart failure. According to guidelines, heart failure with reduced ejection fraction is said when the ejection fraction is less than 40%. Well, coming to the managing heart failure, well, the principles of managing heart failure that first we have to treat the congestion, then we have to treat the risk factors associated like hypertension and CAD, then treat the comorbidities also with the heart failure like anemia, CKD, COPD, and we have to target the neurohormonal activation system. Well, coming to the comorbidities in heart failure, well, iron deficiency is a comorbidity that goes unnoticed in heart failure. And according to 216 ESC guidelines, well, it has been mentioned that iron deficiency causes decreased exercise performance, impaired health-related quality of life, and worse prognosis. And therefore, these guidelines have recommended the diagnostic test in patients with heart failure that includes the measurement of ferritin level and the measurement of transferrin saturation. We call a patient as having iron deficiency when the serum ferritin is less than 100 nanogram per ml, or when the serum ferritin is between 100 to 299 with transferrin saturation less than 20%. So these parameters has to be taken for all the heart failure patients, and if they are iron deficient, then the intravenous ferric carboxyl maltose injection should be given to treat this iron deficiency. And it has been proven by FAIR HF and Confirm HF trials that if you replace the iron deficiency with injection intravenous ferric carboxylase, it alleviates the heart failure symptoms and improve exercise capacity and quality of life. Now, coming to restoring the neurohormonal balance in heart failure, as we all know that during heart failure, there is a stimulation of RAS system and the sympathetic activation. So they are leading to vasoconstriction, fluid retention, fibrosis, and hypertrophy. So these neurohormonal balance has to be taken care by decreasing the compensatory mediators like to increase the nephrotic peptides, to increase the nitric oxide, the prostaglandin levels in bradykinin. This mechanism, can be controlled by one of the important drug, which is which we call it ARNI, that is angiotensin receptor Neprilysin inhibitors that have come into the scenario, and this is one of the very important drug nowadays to treat the heart failure. When we talk about this drug, it's a combination of valsartan, which is an angiotensin receptor antagonist, with sacubitril, and this is a Neprilysin inhibitor, and this comes in a mixture of 1:1 in the ratio. How does it act? Basically, this combination, the sacubitril and valsartan, basically, it on the one side it blocks the angiotensin 2 action by blocking the angiotensin receptor, and secondly, by increasing the level of nephrotic peptides, bradykinin substance P, which causes diuresis, natriuresis, vasodilatation, and decreased myocardial remodeling. This is because these nephrotic peptides, bradykinin substance, these are being inactivated by neprilysin enzyme. So this sacubitril inhibits the neprilysin, thereby raising the levels of nephrotic peptides. There's a trial called Paradigm HF trial, which has clearly proven that if we use this ARNI as compared to the enalapril, and there's a trial which was followed for around 27 months, and in this case, the patients were of NYHA class 2 to 4 heart failure patients, LV ejection less than 35%. And in this trial, the primary endpoint was cardiovascular death or heart failure hospitalization. And it was clearly proven that in this trial, there's almost a relative risk reduction of 20% when used enalapril when this primary endpoint was considered. Coming to the individual parameters like cardiovascular death, it also showed it decreases the cardiovascular death by 20% and heart failure hospitalization by 20%. And the most important part that, as we know that ASM ARBs, they decrease the mortality by around 15 to 18%. But if you use this ARNI, it further reduce the mortality by 20%. That is, it's just above the ACE and ARBs level. In the heart failure, there's always an illusion of stability in heart failure patients. But in this trial showed that 20% of the stable patients, so-called stable patients in parent trial, had a primary event. So a strategy of deferring initiation of sacubitril and valsartan until clinical deterioration occurs is likely inadvisable. So this ARNI has really shown a paradigm shift in the management of heart failure, in the sense that obviously, though we are using these drugs in the chronic heart failure patients, but now there's a trial which is known as Pioneer trial also, which have shown that at least one can start this ARNI in the hospital during the hospitalization. And hospitalization is a key moment to optimize the treatment of any patient. So one should try to initiate this therapy during hospitalization for long-term use. There's a trial known as Pioneer HF trial, which was done in acute decompensated heart failure patients. After the patients were initially stabilized, this drug was started even in the hospital. And it is clearly shown that if this drug is used in the hospitalized patients, there's an early clinical benefit of ARNI in acute decompensated heart failure patients. And it has really shown that the NT-proBNP levels have gone down, and the cardiovascular death or hospitalization for heart failure, there's a relative risk reduction of around 42% by the end of 8 weeks. So by using these new drugs, for example, with ARNI, with beta blockers, with MRA, with drugs like epinephrine and spironolactone, if you use all these combinations, then the hazard ratio is almost 0.37%. So if you use these three new drugs, ARNI, beta blockers, MRA, there's a relative risk reduction of almost 73%. Just see that if you use just one or two drugs like ACE or ARBs, it's hardly decreases, the hazard ratio is hardly 0.88. But if the new combination is used, the hazard ratio is 0.37. So the guidelines have clearly proven that ACE, ARBs or ARNI in conjugation with beta blockers plus MRA is class 1 indication in any chronic heart failure patient to reduce the morbidity and mortality. And even if the patient is stable on the ACE or ARBs, one can replace these drugs by ARNI, and this is also a class 1 indication. Now, reverse cardiac modeling, as we all know, is defined as improvement in ejection fraction, remains an important primary therapeutic target in patients with heart failure. And heart failure therapies that lead to reverse remodeling also foster significant improvement in prognosis. And it has been shown that guideline-directed medical therapy may improve the remodeling indices and reduce heart failure patients. Therapies like resistance therapy, beta blockers, renin angiotensin inhibitors, and MRA, they've already proven that they can, improve the remodeling. And ARNI is also shown in the same way. This has been proved by the trial PROVE-HF study. And in this study, the 12-month follow-up was there, and it has clearly proven that 25% of the subjects experienced an ejection fraction increase of more than 13% at 12 months. And there was, the LV mass index fell from 124 to 107 gram per meter square. So the early initiation of ARNI is beneficial in acute decompensated heart failure after stabilization, even in the hospital setting. So with these, the trials of Neprilysin has shown that Neprilysin inhibitors may potentially reverse cardiac remodeling, and early initiation of ARNI is beneficial in acute decompensated heart failure. Now coming to another class of drugs, which are really promising in the heart failure patients, are sodium glucose cotransporter 2 inhibitors, which we call SGLT2 inhibitors. Basically, this drug is a glucose lowering agent, and it blocks the SGLT2 receptors on the luminal surface of the proximal renal tubules. And it has been proven the mechanism behind how they function is that they decrease the cardiac preload by causing natriuresis, by causing diuresis and glycosuria, and thereby leading to decreased intraglomerular pressure. So there's a decreased cardiac preload. Number two, these drugs have also shown to decrease the cardiac afterload by improving the endothelial function, by decreasing the arterial stiffness, and the decreasing the vascular resistance. And besides that, we have also different mechanisms. For example, the SGLT2 inhibitors increase the metabolic efficiency of the heart, decrease the oxidative stress, decrease the fibrosis, and decrease the neurohormonal stimulation. So all this leads to there's a LV diastolic improvement, this function, and it has also proven that by this mechanisms, LV mass also decreases. And similarly, the trials, there's a one trial, EMPA heart trial was there, which has clearly proven that this class of drugs can lead to decrease in left ventricular hypertrophy. Though they behave like diuretics, but there's a lot of difference between SGLT2 inhibitors as compared to diuretics in the sense that the interstitial fluid, the volume is more reduced as compared to the intravascular volume. Then, as we all know, we have got a different class of SGLT2 inhibitors drugs, like we have got empagliflozin, canagliflozin, and dapagliflozin. And initially, when these drugs were started for the diabetic patients, these the trials were done to prove the cardiovascular safety of these drugs. And we have got a trial like ENFOREST outcome trial with empagliflozin. We have got CANVAS trial with canagliflozin, and we have got declared TB58 with dapagliflozin. And in all these, they have clearly proven, well, statistically, well, there's a reduction in 3-point MACE by 14% in compared to empagliflozin. And compare to the CV death, like in EMPA outcome, there's almost a relative risk reduction of 38% when cardiovascular death was considered. And all-cause death was also reduced by 32% with EMPA outcome. But in all these drugs, whether you take EMPA, DAFA, or CANA, in all these trials, they've clearly proven that if you use these drugs for reduction of hospitalization for heart failure, there's a relative risk reduction at the tune of around 35 to 40%. So clearly, in 2019 ESC guidelines have clearly proven that EMPA, CANA, and DAFA are recommending patients with diabetes and cardiovascular disease, or if they are very high or high cardiovascular risk, to reduce cardiovascular events. And in the management of diabetes, the SGLT2 has been placed, and even if a patient is a drug-naive patient of diabetic and he has got atherosclerotic cardiovascular disease or a high cardiovascular risk, you can start SGLT2 inhibitors as a monotherapy also. Now, the DAFA, we have got the very important trial, DAFA HF trial, which has been presented a few months back. It's clearly proven that the primary composite outcome, the cardiovascular death, heart failure hospitalization, and urgent heart failure visit, was reduced by 26%. And components of primary outcome, cardiovascular death, was reduced by around 18%. And the best part of these drugs are effective in all subgroup of patients, whether the patients have got they are in atrial fibrillation, whether they have got diabetic or non-diabetic, whether they whether they are male or female, whether the age is more than 65 or less than 65. In all age groups, they are effective. Whether the patient is diabetic or non-diabetics, this drug is favorable in all the circumstances. And besides cardiac, these drugs are very good in preventing the renal dysfunctions. Similarly, we have got an Emperor reduced trial with empagliflozin, which the trial was conducted with around 3,700 patients. And in this patients, the baseline ejection fraction was around 27%. And this trial also has proven that if you use the primary endpoint was basically to reduce the cardiovascular death and hospitalization for heart failure, it was reduced by around, the relative risk reduction was around 25%. Similarly, the hospitalization for heart failure, relative risk reduction was around 30%. And similarly, the renal outcomes, the results were also very encouraging. The relative risk reduction in renal dysfunction was around 50%. So DAFA, HF, and Emperor reduced should be sufficient to establish SGLT2 inhibitors as a new standard of care for patients with heart failure and reduced ejection fraction. And there's also some, comparative analysis of 3 randomized controlled trials, like Emphasis HF trial, which was known Epidendron, Peregrine HF trial, and DAFA HF trial. In this basically, these trials, they estimate the lifetime benefits if you use all these 3 drugs. What they did in this trial, that they compared the conventional therapy, which whenever we give the patients like ACE or ARBs, beta blockers, and diuretics, which was compared with a comprehensive therapy for heart failure patients. Comprehensive therapy means when we are using MRA, ARNI, and SGLT2 inhibitors over the conventional therapy. And when this comprehensive therapy was given, so both the groups were, they were studied, and they were to estimate the lifetime gains in event-free survival and overall survival. And it was clearly seen that when you use the comprehensive therapy, which includes MRAs, SGLT2 inhibitors, and ARNI, it favors the comprehensive therapy. And you can see, if you measure the event-free survival in the comprehensive therapy, the event-free survival was around 14.7 years, while in the conventional therapy, the event-free survival was 6.4 years. So if you use the comprehensive therapy, the difference is huge. Event-free survival is almost 8.3 years. Similarly, if you talk about overall survival, if you use the comprehensive therapy, the difference is almost to the tune of 6.3 years. So clearly, the combination use of ARNI, beta blockers, MRA, and SGLT2 inhibitor as a new therapeutic standard is there, and this analysis projects long-term benefits of these therapies if we use over a lifetime. So, so this is the final slide, which is showing how to manage these patients with reduced ejection fractions. Well, we can start with the ACE, beta blockers, and diuretics. But if you feel for patients with persistent volume overload, one can titrate with the use of diuretics. For patients who are persistently symptomatic, African Americans in NYHA class 3 or 4, you can add hydrolysine and isosulfide dinitrate. And the patients still who are in ACRBs, and if still they are in class 2, class 3, you can switch these patients to the ARNI. Another set of patients, for patients with ejection fraction, GFR is more than 30, or if the potassium is less than 5, you can add the aldosterone antagonist. And finally, if even the heart rate is more than 70, in spite of the beta blockers, one can add ivabradine. And with this, even if this best of medicines, if it is not controlled, if the patient's in the refractory NYHA class, then obviously one has to go for ICD, CRTs, and device therapy. Thank you very much.